Yeah, we're gonna do some NCLEX questions. Of course, you're always free to go. This isn't mandatory because it's Tuesday. There's no clinical on Tuesday. Hey, Jay. Yes, that's true.
All right, I'll talk to you later. Bye.
Any questions right now? Jessica, hi. Zoe, hi. Hey, Kevin. Welcome. There are 18 people on. Text in the chat. So questions. We have about 3 more minutes. Normal class times, yes. Lecture will be in the Zoom room. The good thing is I'll be able to draw. Obviously, that's pre, that's intra, and that's post. And I'll be recording lectures. Also recording the current objectives, myasthenia gravis, Guillain-Barré for the midterm, and everybody should know acute kidney injury, liver, pancreatitis. For the renal exam. I'll be posting the recordings of the videos post. So I did the acute kidney injury intrarenal videos, and I'll be doing the ICP, the Guillain-Barré, the myasthenia gravis videos that I'll post to Nursing Camp and YouTube. However, these Zoom sessions will be recorded as well. So when I do the NCLEX questions, and NCLEX questions are going to be based on, just to keep ourselves fresh with current NCLEX questions and NCS, BN, BN.com, org. No test review. That's mainly because of the test will be delivered most likely online. Not 100% sure when that will be or the date that will be. That's why the renal test is to be determined. However, tentatively, it's Tuesday. We were supposed to have a meeting today at Maria on campus. However, that got canceled. So once we get that ironed out, we will know where we'll be testing. Yeah, I'm recording the Zoom videos as we move on, and I'm not 100% sure how much data they're taking. So post lectures, I'm going to be either posting it to Nursing Camp or to a Dropbox, just because I don't know, because Mesa doesn't allow us to have so much memory when we post those videos. Ashley, Amber, 2 iPhones.
Michael, wrap it up.
Sam Camp is open to us right now. I'm not sure about that. Angela would know that. I know they're under different things because we're connected with St. Peter's and Maria College. So we're still trying to figure out, and that's why we were extended another week until we can figure out what the plan is for that. These sessions right now are just to work out the kinks, see people are able to log on, and to see whether we can share screens and different things like that. If the test is online, is it going to be through a program that we need to download at home or something out of Mesa? Testing will most likely be through ATI's Proctor. If it is done online, they have certain mechanisms in place to keep you on the screen. So if you leave the screen, we're aware of it and all that stuff. Also, this is part of the Zoom where people will be sharing their videos if they have them. And we're working on the Proctor piece of it. I'll have some more information by the end of the week. Now you download at home, something off of Mesa. Test online, how does it work? You'll log in, you'll have, so we've done this in the past with ATI proctors, where you log into the ATI system and that locks down your computer screen. And what happens is you take the test and it monitors you, just as the NCLEX would monitor you on the test. And then you log in and then you do it that way. But that's not 100% sure yet. But that's what it's going towards. I'm still working on having a paper testing, but we're still looking at the ability to do that within the facility. Katie's just smiling. Just a smile. It's okay. Any other questions?
Michael? Yeah. Okay.
It is in the bottom left corner if you need to join and mute. Thank you, Jessica. To everyone. If we do online tests, is the room to write out the process? Yes. If we're doing it in person. Well, the big thing is trying to figure out the social distancing and the nuances of testing right now. I'll have more of an answer on Friday as far as what the process would be for that. Like I said, these Zoom sessions are mainly to get people logged on, get comfortable with it, to see the screen, to share screens, to work on opening up PowerPoints and to share these PowerPoints and to kind of move through presentation so that we're able to deliver the lectures in the same way that we would normally do them. Online open notebook. I'm not 100% sure on that, Jessica. Now we're trying not to do open audio, just mainly because of feedback and just chaos in the room. So that's kind of where we're staying to this chat box, so this group chat, to keep it open, especially when we start to do questions and we start to base it on that. Any other questions? There's a previous lecture, which is an open session, that's posted on Mesa, and some of the questions in regards to the process of that previous session. These sessions are not mandatory, as well as the lecture is not mandatory, which will be on Tuesday and Wednesday at our normal class times. NCSBN is the NCLEX testing site, and that is what outlined that the new testing changes have happened. 60 questions for the NCLEX, and 145 or 165 maximum questions, and only 4 hours of maximum time allotted for this test. So that's a change for the NCSBN site. I posted on Nursing Camp and also my Facebook page. You can go to that site and see these changes, and it's mainly in regards to COVID. Now we'll have an NCLEX talk on NCSBN.org. Make sure that's right. Let's see. Yeah, that's the correct site. That's the National Board of Nursing, and that's where the NCLEX is actually written. And they put out a notice about the new testing policy up until about June. That's an advantage to you because there's going to be 60 questions on the NCLEX that are the minimum amount of questions. Now, my thought is that there's 15 questions that don't count on the NCLEX, on a normal NCLEX. And I think that they're eliminating those 15, and that's where they got the 60 from. So they're not doing any evaluation during this period. Any other questions? All right. See if we can get into some questions here. Let's kind of roll through it. All right, so first question, you work in the emergency department when a client arrives reporting substernal left arm discomfort. It's been going on for about 3 hours. Which laboratory test is most useful in determining whether you should anticipate implementing acute coronary syndrome standard protocol? Yeah, I think that I'm going to sit back and I'm going to want you guys just to think about it. And you can't really click it because of, we're still working on this. And that's kind of what the premise of this is, to kind of work on this process. Then what we're going to do is all right, so acute coronary syndrome. So that's the key here. So the acute coronary syndrome, you have the emergency department. When the client arrives, they're reporting. Okay, so the client is, reporting that they're having leg, arm, if it's going on for 3 hours. Which laboratory test is useful in determining what should acute coronary syndrome in a standard protocol? All right, so it goes back to this cardiac enzymes and this, where you have MB that's over here, myoglobin, which is also called MB. So it is too, it's troponin level. All right, so this is a content-based question, whether we know about what acute coronary syndrome is and what the test is related to it. All right, so let's move to the next one. Now, my point is to kind of get into doing questions that are a little bit more working on the process and then working on these questions. So I'm going to try to pick some more questions. I think the benefit of this, these Zoom lectures is going to be, oh, we lost somebody, so we're down to 17. So obviously, can't we play Kahoot still? Yeah, we could probably play Kahoot, but let's kind of go through some questions. I mean, you know, primarily is to try to do as many questions as possible and to, you know, prepare ourselves for the NCLEX and set to move forward. So let's go to the next question. And here we go. You're monitoring a 53-year-old client. Ah, crap. And this is the point of this, is to work through the kinks.
Michael,
Can you make that bigger? That's a great question.
you ready? Great.
Can you see that? Is that better? All right, so let's get into it. So we have you're monitoring. So what are we monitoring? That's the first question, right? Client undergoing a treadmill. All right, so some basic things about treadmill is that we're worrying about, you know, ST depressions and signs and problems. Why do they get a treadmill test? Is to elicit the whatever symptoms they were getting before, which is generally chest pain or anything like that. So if they go for a treadmill test, you were trying to bring back the chest pain. So we need to know about that. So which finding requires the most immediate action? Okay, so with blood pressure, yes, that's high, but that's not the relationship to what would happen on the treadmill. Heart rate of 134. Well, we want the heart rate generally elevated with the patient who's on the treadmill, and that's okay. Oxygen saturation, okay, well, that's a problem, so we're going to keep that. And then we say chest pain. Well, chest pain is just like having ST depressions and ST changes. When we have a patient who's having chest pain, that means that they're repeating the reason of why they're having this treadmill in the first place. And so chest pain tends to be the priority answer in the priority question. It's the same problem as far as if you saw ST depressions on a treadmill. So the key here is with this is this 91% is a distractor. And the reason it's a distractor is because, yes, the oxygen saturations are low. However, this pain level is an actual problem. So this pain level of 3 is an actual problem where this oxygen saturation requires assessment, but this is an actual problem of why they're on the treadmill, and that's why it's the priority answer. All right, next question. All right, so healthcare provider provides these actions for a client who's admitted with acute substernal chest pain. Which actions are appropriate to delegate to an experienced LPN who is working with you in the ED. Give you some moments. I'm going to work on this part. This is obviously a problem. All right, you should be working on this on your own. All right, so this is a true-false question, right? So it's a select all apply. So within the scope of practice, and that's the priority thing. So within the scope of practice of a LPN, could they attach the monitor leads? So that's the first question. And that's a true, right? They could do that. There's nothing wrong with being able to attach the monitor leads. Could a tech do it? I mean, it's not a delegation question. So yes, but an LPN could do that. The next is give heparin 5,000 units IV push, right? Well, what's the question talking about? Who's admitted with a subcutaneous, which actions are appropriate to delegate to an experienced who's working in the, well, IV push is the key problem with that. So we're not going to do that. And so they can't do the IV push. So let's get rid of that one. So that's a false. Next is administer morphine IV. Well, that's another IV. So no, they cannot do that. That's going to require assessment. So we're not going to do that. So the next thing is obtain a 12 lead EKG. That is also true. They could do that. If they're able to attach the leads, then they could be able to do this. And aciclate and history. Well, no, they can't do any history. And that's assessment. So no for that. And have a client chew and swallow aspirin. And they could do that, yes. So this 1, 4, and 6. And can the LPN do anything with an IV, or was it just about those meds? Generally, no first IV pushes. So the LPN cannot do IV pushes, only with expected outcomes. So when you're giving IV heparin, that's an acute process. When you're giving IV morphine, as an acute process, requires immediate assessment. So generally no new IV medications or any IV pushes. All right, ready for the next one. Any other questions about this? This takes a little while. I apologize for that. So I'll try to figure out that. And let's go to the next thing. Oops, hey, what's going on over there? All right, sorry about that. All right, so next question. All right, so next question is for skipped, go to 5. I lost another person, must be boring people. All right, so you make a home visit to evaluate a hypertensive client who's been taking enalapril, which finding indicates that you need to contact the healthcare provider about a change in the drug therapy. Client reports frequent urination. Client's blood pressure is 136 on 48 or 86. Client coughs often during visit. Client says, I get dizzy sometimes. With that said, read the EKG. Would it change it? No, they cannot read or interpret the EKG. Guys, answer it in your head. Yep, that's fine. Yep. I mean, we're trying to figure that out. So what will generally happen is I'm going to give maybe a time frame and then say, okay, I'm going to start to answer the question. Does that work? All right. All right, so we're going to give a basic time frame on it and do about like 20 seconds or so. I mean, you know, as far as the NCLEX is concerned, I mean, with that new guidelines, you're going to only have a minute to answer questions. So I don't think we need to take a minute during this time, but let's, boy, yeah, okay. All right, so what's this talking about? So let's talk about this. So you have an allopril right here. Well, it's an ACE inhibitor, right? So ACE king high, angioedema, cough, electrolytes, potassium high. So let's go into it. Reports frequent urination. Well, thanks for that. Clients, okay, requires assessment. However, I wouldn't do a change based on this data. Client's blood pressure is 138 on 86. Not bad, but not great. All right, I wouldn't do a change. What was the blood pressure before? Client coughs during the visit, often during the visit. Well, that's related to ACE king high, cough, electrolytes, and I get dizzy. That requires assessment. So it makes 3 the credited answer, and that makes the correct answer. All right, next question. All right, a little bit longer, so take some time with this one. Do you think I should read them, or you should read them? Okay. Yeah. Yes, you can read. Yes, Veronica. All right, so select all apply. So true, false, true, false, true, false. All right, so let's look at the first one. So let's look at the question first. While admitting a client, you obtain information. So we're assessing, okay, about cardiovascular risk factors. Okay, so what this question, so what's the concept? The concept is modifiable versus non-modifiable. So let's see what it goes on to. Mother's asking 2 siblings had MIs. Okay, so that's a, choose your parents wisely, right? So there is no really change on that, so you can't really change your parents. So there's a problem right there. The client smokes. Okay, well, that's obviously a problem. She works at a mail carrier, involves walking, so that's good for her. Takes metoprolol, so specific for hypertension. Her blood pressure has been in the range of 130s to 138s. That's okay. We want that less than 140, and then systolic we want less than, diastolic we want less than 90. Which interventions will be most important to change a plan? Okay, so, okay, yeah, that's true. We'd want this one, so we're going to click that one. Teaching about impact of family history, we also identified that the history is a problem. Education about the need for antihypertensives. Well, there's no real change there. Assistant reducing this. Well, there's nothing about stress here, so no. Discussion about the risk associated with having a set. Well, she walks regularly, so that makes those 1 and 2 the credited answers. Are we good? I'm going to assume you're good because I'm just going to keep on moving through them so we don't waste a lot of time on them. Any questions? Yeah, it's a straight up content question. Select all apply, which makes it a passing level question because select all applies require you to second guess and to reevaluate what your content is. All right, you're working in the ED. Yeah. All right, let's look at this question. All right, so you're working in the ED caring for a client. Okay, so you're working in the ED, you're caring for a client who is just admitted. All right, and as we know that when patients are just admitted, certain things are done for this protocol because they're admitted. All right, so for left anterior chest pain, so assessment has been done, possible acute coronary syndrome. And we said that acute coronary syndrome is a blanket statement, which generally could be an MI. It could also mean that the patient has angina. All right, so it's a couple of different things under acute coronary syndromes. Which action? So what will I do? Take first. Okay, well, put an IV in. Okay, that's an implementation. Assessment. Okay, administer sublingual nitroglycerin. That's implementation. And draw blood troponins. Okay. All right, so we have three different situations here. We have insert an IV catheter. Okay, well, that's invasive, first of all. So generally most invasive, we go least invasive to most invasive. So no, but we need to look at this assessment first. So auscultate lungs, heart sounds. All right, so let's look at that assessment. All right, so with chest pain and auscultating heart sounds, what do we auscultate heart sounds for? Well, we talked about that in lecture where we talked ape to man. And generally, heart sounds are relative to either S3, S4 sounds, okay, which are usually problems with the valves. And if we have problems with the valves, we usually have murmurs, and it's about fluid, or a PE, or a tamponade. And those are the main reasons. That's why we listen to heart sounds, is for either fluid, PE, or tamponade, or pericardial friction rub. So is that what's going on here? Is that the proper assessment? So a lot of times, so if we're looking at this question, sometimes we just think, oh, assessment is first. Well, is it really though? Because is it the right assessment? So it's the same thing as if it said, assess bowel sounds. Because, if it said bowel sounds, you would say, well, why would I assess bowel sounds? So just because it says heart sounds, it doesn't necessarily mean it is so. Because heart sounds is very specific to specific problems like heart failure, cardiomyopathy, hypertrophic hearts, and different things like that. So does the assessment make sense? So if you pick that, you have to kind of think about why did you pick it, just because it was assessment first. So that's actually an incorrect statement, assessment. The next is administer sublingual nitroglycerin and then draw blood for a troponin. Okay, so we have do something invasive, give this medication, or draw bloods for a troponin. If the patient was admitted, can you assume the sounds were already assessed? That's a good statement. Yeah, I mean, a lot of times when we assess for further information. Now, they're already admitted with left anterior chest pain. So they're already there. So they're having this anterior chest pain. And in case you're trying to wonder, is it okay, is it pleuritic pain or is it just, trauma, possible ACS? So you would have to have that understanding that ACS is a myocardial issue or something that is wrong with the heart. And so that's kind of why that's there. So which action we take first? And this is a protocol question. So the concept is based on protocol. Well, draw blood for troponin. That doesn't seem like that's bad. Okay, so yes, and then give sublingual nitro. And so let's see. Okay, so we're not gonna put an IV in. Let me see what we got here. Still working on this. And then I would say give nitro. Yes. All right. So the priority for the client is with unstable angina, MI. It is wrong to automatically think HONA MB when approaching this question. You're admitted. So that's the key with this question is that they're admitted with left possible ACS, which action will you take first? Well, because the thing is in the first action, so all assessments should be done, right? So yeah, that is true, Amber, But the key here is that, I have a little bit problems with this question because of, are they still having chest pain? And that's kind of where, when we're doing questions like this, they're kind of here for that discussion, because is this question 100% written? Right, exactly. I don't like it either, right? Because is it 100% correct? Now, the priority of the client is unstable angina, MI's treatment of pain. Important to remember, assess vital signs before administering sublingual. So other activities should be accomplished, but are not as high priority. And this is a question. What they're saying is about perfusion, and perfusion. In order to get perfusion, would give the sublingual nitroglycerin. I wouldn't require more data. However, this data right here, auscultate heart sounds, is not the correct assessment. Draw blood for troponin measurement. It's not changing the patient. It's not about the patient. That's about what I think is going on. And doing a catheter, that doesn't make any sense whatsoever. So the most correct is, as far as changing the patient right now, is sublingual nitroglycerin. Remember, when I pull these questions together, and the main reason is kind of for this discussion. You could not like it, Caitlin, but it is the correct answer. All right. Next question. Soupy poopy. Yes, it is not too. All right, so let's get into this one. So we have an 80-year-old client with coronary stepped-down unit, tells you he doesn't want to take Colace, or he's soupy poopy, right? So he doesn't want to have any problems because he doesn't have any problems. Which action is most appropriate? So document the medication. Okay, that's a do nothing response. Mix the medication with food. Well, what kind of food? Doesn't make any sense. And administer to the client. So obviously just ignore what the client's saying. Explain the decreased activity. Okay, that's actual data. It's about what actually the medication would do. So we're going to keep it. Reinforce the Duke-based is prescribed for, what good reason, right? That's not factual enough. So it makes 3 the credited answer. More questions like that, right? All right, so let's talk about it. So you're given morphine sulfate 4 milligrams to an IV. All right, so first question is 4 milligrams. You know, what's the difference between 4 milligrams, 6 milligrams, 2 milligrams, or 4 milligrams? Okay, so let's move on to the next part. Who has an acute MI? Okay, what kind of MI? It's the second question. So when you evaluate the client's response 5 minutes after giving the medications, okay, expected versus unexpected findings. Which finding indicates a need for immediate further action? So what's unexpected about this? All right, so you're given morphine for an MI. Right, so the action of giving morphine for MI is preload as well as pain. So let's go into it. So blood pressure decreases from 114 to 106. So there's nothing wrong with that. Mean arterial pressure is fine. Don't worry about that. Respiratory rates from 18 to 12. Okay, well, that's problematic. I'm going to keep it, so I'm going to move on to it. Next thing is cardiac monitor indicates sinus rhythm. Okay, whatever. And then the next thing is persistent chest pain. So persisting, right? So the patient still has, so I've given them morphine 5 minutes later. And so according to the protocol, is that by the chance of giving morphine, you know, did I go 3 times? I've given the nitro, and I've given the morphine now, but it's persistent. So I have persistent pain after giving morphine in a pain level of 1 on a scale of 0 to 10. So I have a potential problem here, and then I have an actual problem here, because the goal is to go chest pain free, right? Or we're going to do something more invasive as far as a PCI or some sort of other intervention. So let's see what we got. And the goal of pain management for the client with an MI is to eliminate the pain. And even if pain is rated 1 out of 10, an additional morphine, although possibly a lower dose, and that is risk. So this was mainly the distractor, the 18 on 12. Right? And we talked about that before. We said that we don't really worry. 12's low, but 10's lower, 8 is intubate. And then we move on. All right, so we're going to take a quick break. Any questions about class, anything that might be happening in class, anything that you might have up till now? Is how fast is morphine supposed to work? Because 5 minutes threw me off. It's IV, so it should work pretty much within onset, within about 1 to 2 minutes, 3 minutes. Yeah, it's not like a PO medication. So generally, if it's IV, it's almost immediate.
Ready?
Any other questions? Is this helpful? Can you get to the system at home? Yeah, this is right from your priority delegation book. I want to use different resources throughout the process. I'll do, this is just questions going through a question database. However, I will do, just PDF questions. The good thing about these sessions is I'm just going to keep on just doing questions in different formats, just to show you just how to answer questions. We'll do some Kaplan questions, Saunders, Davis, Lippincott, UWorld, and all these different resources that are out there. How long is break? Well, this is the last week of break. Next week we'll start lecture on Tuesday. However, like I said before, renal test might be on Tuesday. No Zoom break. That's exactly right. And now the Zoom sessions are going to be pretty much like this, where, I'm just going to basically put them out there periodically, because I think the biggest key would be doing a lot of questions and preparing you guys for the NCLEX. Any other questions? We're going to meet on Zoom as a class at a regular class times. Yes, we will meet on on Tuesday at 10 a.m., depending whether or not the exam will be on Tuesday at 10 a.m. So I'll know that on Friday. Yeah, 10 a.m., not 9:45. Yeah. And like I said, a lot of the lectures are going to be recorded, myasthenia gravis, Guillain-Barré, for the next session, ALS. And then when I do ICP, autonomic dysreflexia, spinal shock, neuroshock, I'll have all the videos made for those. And then what we'll do is the priority will be doing NCLEX questions, sets. So I'm going to try to do 10 question sets per. So like I'm going to shoot for 20 today, and once we hit 20, then we'll be done for tonight. I'll set up a schedule because we won't be in clinical. We'll be doing Zoom rooms. We'll be doing case studies, and we're just going to really be massaging the content for NCLEX. Yeah, please correct. Send your resumes to me, email, and then I can correct them and then send them out. You should be applying for positions at this time as well. All right, next question. Caring for a hospitalized client with heart failure is receiving captopril or craptopril. Yeah, he's king high. I mean, if you missed this, I mean, please NCLEX give us this question, right? I mean, this is everything written all about, everything that we've talked about at this time. So ace king high, captopril taken with food, spironolactone, high potassium. So high potassium all the way. Okay, next question. Do I think my style will over prepare us for the NCLEX? Well, as I start to progress in the semester, we'll start to have more of my style questions in there, because we'll start to, I mean, the big difference between these questions and my questions on my exam is I'm splitting hairs and I'm really trying to teach specific things. You'll start to pick it up because we're doing more quantity of testing. So as we do these Zoom sessions, we're going to do a lot more questions than we would do during class. So I'm starting to warm up to specific things, even though you might find these easier than what you'll find on my tests. They're still, challenging on different aspects. So, and they're here for a certain reason. So as we move on, I'm starting to build those. I wasn't prepared to set together like test banks for this. So I'm working on it right now. So to meet that objective. All right, so here's a good question. All right, so prescriptions of unstable angina, he's already taken clopidogrel or Plavix, right? So patient has a stent, which medications clarify further with the healthcare provider. All right, so here's an interesting thing because you have aspirin here, all right? So 162, it's a very weird dosage range, so we're gonna keep that. Then we have a meprazole, all right? So that's also odd, as far as like, why is that there? Okay, so then we have metoprolol. Right, well, we know that's related to the heart. And we're looking at, that's beta 1, so it's not beta 2, and nitro patch has nothing to do with what's going on. So we can limit these last two. So now we're down to these two here. All right, so we have Plavix, which is generally for stents, or clopidogrel. And we know that the anticoagulants, and so what's important to clarify further, right? So in actuality, let's see some answers out here, what we have here. So, it's actually two, believe it or not. Prilosec is an H2 blocker when has the, I know, right? Can you believe it? So decreases its effectiveness because of the way that H2 blockers get absorbed in the stomach. Now, I would have been generally on that aspirin right away because it's too similar to, clopidogrel. And at this level, you have this weird sort of, and you think about GI bleeds, and you think about GI bleeds and absorption mechanisms. And when you're looking at that in the H2 blockers, a lot of times that we don't even think about like these kind of medications when we're looking at Plavix or clopidogrel. And that's kind of why, questions are very important. Because sometimes what we immediately see is like, okay, it's a bleeding question. This is what it is. And then, that's why we do the questions like this. And this is why I pull these questions in here, is because a lot of times it's like, oh, I never really knew that about that. And where is that in Davis? And so sometimes you overlook it. And that's why questions is priority. And I think that that's going to be the benefit of these sessions and the amount of questions that we're going to be doing, because we're going to look at these types of things. This will also show up when we do our AWALS presentations, and that's the reason why we do the AWALS presentations, because sometimes we hammer down on such concepts of bleeding, but we don't look at these little nuances that show up. And that's where, antibiotics and Steven-Johnson syndromes. Yeah, so would any blood thinners, Prilosec, be contraindicated, or is it just Plavix? Generally, because Plavix is chronic and omeprazole is chronic. So that's kind of where it comes into it. So where, that's how I would look at it. As far as like Coumadin and different things like that, the absorption of Coumadin is, I think, enteropathic, so it doesn't necessarily gets absorbed necessarily in the stomach. So that's up for debate. I'm not 100% sure on that. All right, a couple more to go. All right, let's get into it. So at 10 a.m., okay, so the morning, so thanks for that. Hospital client receives a new order, all right, for a TEE, okay, so transesophageal echo, so a risk for aspiration as soon as possible, okay, so which action we take first? Well, they're going to be sedated, and they're going to have a tube stuck down their throat, so that's important to know. So risk for aspiration. All right, so put the client at NPL. Okay, well, that's good because risk for aspiration. Don't eat any hamburgers or White Castle burgers. All right, so teach the client about the procedure. That's also important. So I'm going to keep that first. Keep that as well. Insert, here we go back with the catheter again. Why the forearm? Makes no sense, right? Like, is there a universal forearm? So let's get rid of that. Attach the client to a cardiac monitor because we're going to send them for a TE. That doesn't make any sense. So now we're down to 2. So put the client in MPO status or teach the client procedure. All right. So now when we're down to 1 or 2, which action will you take first? So the priority action is, okay, whenever we have first, we're going to say, okay, well, safety's priority, and we're going to put them in order. All right. So the risk is aspiration. So that's going to be the priority. This would happen first, and then this would happen second. So that makes that the correct answer. And there we are. Yeah, you would do it first, right? So priority is to implement. So everybody on the floor would be basically, you would tell people, listen, hold that tray, don't send anything down there, nothing by mouth. So you would start to do that first, and then you would then tell them afterwards, because you can't control, well, you could control what's going on outside the room and visitors and everything like that. So you could put up a sign right away and then deal with the second thing first. So the priority action is about the safety of the patient versus the explanation of the potential problem that the patient can have. And the potential problem is aspiration. What's the risk of aspiration? Is pneumonia. And that's a 72-hour problem, not an immediate problem. All right, so you're assessing a client who just returned. So classic just returned. So who do you see first? Just returned. Recovery area after undergoing coronary arteriography. Okay, first question is what kind, right? So we don't know. So we know some basic risks, right? So we know we're going to check for pulses, we're going to check for bleeding, we're going to check for hematoma. What's the most important, most concerned? Bleeding, hematoma, problems like that. Okay, so let's look for it. So blood pressure. We have 1 blood pressure. Well, thanks for that. That's not going to tell us anything. So 144 and 78, I mean, it's okay. It's a little high, but it's a potential problem, not an actual problem. Pedal pulses are palpable. Well, we'd be looking for non-palpable, so we're going to get rid of that. Left groin has a 3 cm bruised area. Well, thanks for that. Very specific about that left groin. Bruised, okay, well, that's a potential problem again. And then that. All right, so then apical pulse is 1 in 22 beats a minute. Okay, so this is a question about bleeding. All right, so the concept is that post-coronary arteriography is risk of bleeding and occlusion. Well, Bruce doesn't say bleeding or occlusion. Palpable pulses are okay, blood pressure wouldn't be bleeding, and then this makes 4 the credited answer because of bleeding. And that's most patients do wish, right? Medications, oxygen, stress, trauma, pain. All right, a couple more. Quick unrelated question. Yes. Why am I on the beach? Do we care about BP if the map is below 60? That's a good question. That's a nursing 5 question. And the answer wasn't BP, right? So the answer previously was 122 beats per minute because of that. Kira's drunk. Yes. So she doesn't like wine anymore. So, all right. So number 18, you're working in an outpatient clinic where, okay, next question. I mean, in general, looking at BP. Yeah, generally, that's a nursing 5 thing where we talk about mean arterial pressure. Generally, NCLEX expects that to be a advanced concept. Don't use it as an absolute. All right, so an experienced UAP. So experienced, all right, once again, don't care, right? So anything when experienced LPN, experienced UAP, that's just a distractor, right? It's just to pull you away from, what the ultimate task is. Now, all UAPs are experienced, right? All LPNs are experienced. It's just a distractor. It's all based on delegation of appropriate delegation. Remember, the nurse will always delegate appropriately and within the scope of the person's practice. All right, so let's look at that. So UAP handles stable patients, stable outcomes, expected patients, expected outcomes. They don't do any teaching, and they do what's within their scopes. They can do Foley's, they can do vital signs, they can do blood sugars, but they don't do any assessment, no teaching, anything like that. So measuring the ankle, brachial pressures in a client whom the ankle brachial index is to be calculated. All right, that's within the scope. They can measure brachial pressures in a client, ankle brachial. It seems complex, but I mean, they can measure something in pressures. All right, so it's like, so checking blood pressures and pulse every 10 minutes. I mean, so if somebody's taking the blood pressure and pulse every 10 minutes, that's acute. So that requires some specific assessments. It's not even 15 minutes, 10 minutes. So therefore, that requires ongoing assessment. So we're going to eliminate that one. Next, obtaining information about, well, that's assessment. So we're going to get rid of that one. Next is providing a brief client, no, they can't teach. So the first one becomes the credited answer because this is teaching, this is assessment, and then this is too frequent of assessments during exercise strip testing. I mean, what kind of testing? Unknown, so therefore assessment is necessary. And that makes A the credited answer. Now, a lot of times with this question is that people might look at this and say, I don't know what the hell that means. So therefore, if I don't know what it means, then they can't do it. Well, when you look at the other things, is that you know what this means, and you know what 3 means and 4 means. So therefore, they can't do these things, and that makes that the most correct answer. All right, so 2 more questions, and we'll wrap it up. All right, so while working on a cardiac step-down unit, right, you're serving as a preceptor, newly graduated RN. So newly graduated RN, all right, so RN, so generally they can take discharges of stable patients that don't require teaching. They can take care of patients that have stable patients, stable outcomes. They can take care of general nursing, stable patients with unchanging conditions. All right, so 6-week orientation program, who cares? Which client's best assigned to a new graduate? And that's ultimately what it's asking. So a 19-year-old rheumatic fever needs discharge teaching. Well, okay, I have this rheumatic fever. I had strep. What's going on with that? And why am I taking this medication? Oh, let me go ask my preceptor. Right? Too many questions. Wouldn't be able to field those questions. It's the same thing as far as a discharge of a new stent, and that patient asks you, what's a PS652-3 stent? I have no idea what that means. And then the maternity nurse is like, I don't know. So no, too much over their head. 33-year-old admitted a week ago, endocarditis, a week ago, so stable, expected outcome, receiving Rocephin. Okay, that's an expected outcome, expected treatment, so we're going to keep that. 50-year-old newly diagnosed, okay, newly, right, so unstable, stable angina, that's a distractor. Many questions. Well, how many? I don't know, 200 questions. All right, no, so get rid of that one. 75-year-old has been transferred to the unit after, transferred when? After a bypass grafting yesterday? Well, what kind of I don't know, quintuple bypass. Like too much information, too unstable. That makes 2 the credited answer, the most stable patient. Yep, and this says orientation would include safe administration. All right. All right, last question. All right, so you monitor cardiac rhythms of client and coronary care unit. All right, CCU. So client needs immediate intervention. So stable, unstable, expected, unexpected, most unstable patient. All right, so CB cap. So clients admitted with heart failure, what kind? Right or left, don't know. Has atrial fib with a rate of 88 while at rest. Stable or unstable? Stable. There's nothing abnormal about this patient. Client with newly implanted, okay, how new? Pacemakers, occasional periods of sinus rhythm with a rate of 90 to 1. Okay, stable or unstable. If I'm unsure, I'm going to say unstable. All right, so we're going to keep that. Client has arrived in the unit, okay, when? With an acute MI, what kind? Sinus rhythm, sinus 76, okay, well, what kind of MI? Frequent premature, okay, how frequent? Okay, PVCs, not PACs, ventricles acute. So I don't know about that one either. So I have these both, so unstable. Recently started taking a tenolol, all right, whatever. First degree, okay, first, second, third. First is chronic. There's a rate of 58. Okay, that's a distractor, 58. Potential problem. If I want to say it's unstable, I can say, all right, let's keep it. All right, so we'll next move to the next step, expected or unexpected. All right, occasional periods of sinus rhythm, demand, pacemaker. We could say unexpected. Arrived in the unit, MI. This is also unexpected. And this is actually expected for a first degree heart block. And if you remember with first degree heart blocks, they have that long PR. All right, so they're going to have less of a conduction. So we're going to get rid of that one. Now we're down to 2. Then we have A, B, C's. All right, so A, B, or C, these are both circulation. So now we're going to go into CB cap. So acute or chronic acute, acute, and then we say the last step, PAP, CB cap P, actual potential. Newly implanted pacemakers, occasional periods of sinus rhythm, occasional sinus. Okay, well, sinus. Okay, potential problem. Okay. So now I have to basically assess what's really going on. I need to look at this a little bit more further. So CB-CAP doesn't necessarily work in a sense, even though I get to down to the last two. So now I'm going to go back into, is this an actual problem? Is this a potential problem? Is this now or is this later? Is this more acute or is this more chronic? So let's look at this patient. Implanted demand pacemaker. Right, so it's a demand pacemaker. So it means it's not fixed. It means it's only going to react whenever it needs to. So occasional periods of sinus rhythm, 90 to 100. Well, there's nothing abnormal about that. It's a little high, but it's not like 140s or 150s. And generally with a ventricular pacemaker, I mean, we're going to look at more low, not necessarily high. So because high would be a potential problem. All right, so client arrived to the unit with an acute MI, sinus rhythm 76, frequent PVCs. So frequent, how frequent are they? That's the first question. So I'm going to go with 3 on this, and we're going to see what we get. And we have PVCs occurring and settling. MI can lead to a ventricular tachycardia. Yeah, so that's kind of what we talked about before in class, where we said that PVCs are always acute because atrial PACs are not generally as acute as ventricle, like ventricle tachycardia and all those things. And when you see frequent, you have to ask yourself, how frequent are we talking about? And, if you were to say in a group of 100 nurses, if you said occasional periods of sinus rhythm or frequent PVCs, and you say, who's going to say which is going to be most acute? And that's where this gets a little bit complicated, because this is part of the process of you learning what's acute, what's not, what needs immediate assessment, what doesn't. And that's hard to teach because, all I can do is kind of show you some tricks and how to think about things. But however, you have to ultimately come to that realization that this is more acute. And that's when you look at it, you look at the content and you look at what it says, and then you say, wow, a lot of PVCs, frequent PVCs, that's a little bit more extreme than the others. And that's why 3 is the credited answer. Is there any questions about this? And then there was silence. Was it helpful? All right. So I want you to know that even if I just want you to realize that even if you're getting something wrong, just realize that there is reasons of why, the answers are what they are. They're not tricky questions. So a lot of the questions I'm going to pull here are up here for reasons. And if you really look at it, you can start to see more understanding about like how to answer the questions. And then what I'm really trying to teach is just the assessment of, and thinking like a nurse and thinking about this content in a way that, looks at the words and says, hey, there's something wrong with this. This doesn't make any sense. And I'm going to try to figure it out. And that's kind of hopefully what the purpose of these Zoom sessions are. And I think that, this is going to allow us a lot of time to really look at questions and really start to look at content. And, I'm going to do renal questions. Yeah, I'll do renal questions probably tomorrow, and maybe some GI questions and some liver questions. I just need to start to look at the questions and start to pull things out that are a little bit more helpful for us, because sometimes questions are just too easy, and that because you're on Nursing Camp, or you're on, Saunders, or you're on Lippincott, and you're seeing these questions that are just easy. So I try to find the ones that are just a little bit more challenging, and so that we can see how they answer. We're going to do renal questions tomorrow. Are we doing 8 p.m. again? I mean, does 8 p.m. work? That's the first question. I mean, we should kind of pull that, is 7:30 work or 7 o'clock? Now, these are not mandatory. So just understand that I was told that by the powers that be. You can't mandate people to be on there. And so you know what? They're here if you want them here. And that's kind of where I'm at. I'm just kind of doing this for you guys. So, we can work through the kinks and stuff, but I have free for the rest of eternity. Yeah. 7 or 8. Let's start with that. Oh, somebody jetted out. 7:30, 8:30. 8, please. I'll tell you what. I'm gonna rotate the times. Yeah, I miss the class too. I miss, being. I think it's just there's a whole part of it that is just kind of. However, like I said, we're going to be able to do a lot of questions. We're going to be able to do a lot of things that are, more than previous classes. I mean, you'll spend more time. I plan on doing more, Zoom sessions based on questions like this. So I know Veronica asked about like these questions. This is right from your book, Priority Delegation and Assignment. So that's the book I've been recommending everybody. I mean, I'm going to pretty much kind of go through the whole book. I'll pick and choose the questions out to kind of work on them, because I think that I kind of know what you guys need to work on. And so I'm going to keep on working on those things. And then I'm going to work on, so in the meantime, work on downloading the on the Nursing Camp site the case studies and the order set books, because that will probably be a precursor to the clinical times. However, clinical times will probably be coupled with question sets. So, we might do during clinical, 2 hours of questions or an hour of questions, and then some case studies, and then some more questions. And then, I mean, clinicals will not be 8 hours, but they might be 4 hours. But they're going to be online with Zoom. And then we're going to do, and I'll be able to do the day clinicals for the day group and the evening clinicals. So you'll have the option to be in whatever one you want to be in. Yeah, I think questions are key on this. So, I mean, you guys are just going to get a lot of questions, which is great, because, a lot of the Kaplan and the Elsevier stuff that I've done in the past, I'm just going to pull all those questions and just start doing them for you guys, so that you're able to, because I think that that's going to help a lot. Of course, you'll still be studying the other content, and then we can get closer to where we need to get to. And I'll be recording all these post Zoom into videos. I mean, you don't have to watch them again, but if you want to look at them and stuff like that, for those that like to write down the questions, they think I'm going to put them on the exam and stuff like that. I mean, that's for you guys. And then we can go from there. But most of these questions are all available to you guys anywhere, so you can find them anywhere. You need to a lot about tubes. Just the basic stuff that you talked about. G tubes, order of priority, order of assessment, and so all things that you're validated on. I mean, there's nothing on the exam that you need to restudy. I mean, you should know it going into it. So there's no curveballs on it. You know, I mean, the tests are very manageable. It's just you're fighting yourself. I mean, you had 4 weeks to study for it. I mean, just saying. Yeah, it does make it worse. I mean, we just want to get it over, you know? I mean, get it done. I get it. Are there any other questions? All right, guys, have a good night. I will see you tomorrow night. And stay safe, wash your hands, and we'll talk to you later.